We'll begin by looking at different types of nephrolithiases, or in other words, calcium stones being the most common. Is that clear? So once again, calcium stones will be by far the most common. And then with calcium stones, we will then divide this into two different subtypes. But of all the kidney stones that we'll take a look at, calcium stones, uric acid stones, cysteine stones, your struvite stones, calcium by far is the most common. Now in the table that we see here and the ones that are to come, we shall then divide this into content of the stone. Well, how exactly, what is precipitating, what this may then look like on your x-ray, which is incredibly important. CT becomes important, urine type of crystals if present, and then a few comments. Calcium is where we are. Your focus is calcium oxalate. Also, keep in mind that there is hypocytruria. Hypo, we're in the urine. Take a look at the suffix. On x-ray, if you were to take a look at a calcium stone, you can predict, well, most times when you find calcium nodule, let's say that it was up in the lung or wherever it may be, or if it's calcium in the pancreas, you can expect it to be radiopaque. So that should be of no surprise. On CT, you find it to be radiopaque as well. Now, there are different patterns here, and the patterns are important. The patterns that you'd find with calcium oxalate specifically would either be a dumbbell, or what you're seeing down here is going to be something like an envelope. Something sometimes referred to as being a coffin-shaped calcium oxalate. The most common stone it is. Hypocytruria is associated with decreased urinary pH. That's important for you to pay attention to. Results from ethylene glycol, which is, take a look at the number of E's, the letter E's that you have in ethylene. Conveniently, there are three. There are conveniently three E's in the word freeze. Use that to your advantage, please. So antifreeze, what does that mean? The individual was, during the summertime, adolescents tend to consume things that are rather peculiar. Antifreeze, I guess it looks cool, and so they consume it, and so therefore may result in calcium oxalate. But understand, though, this could just be a genetic issue. Is that clear? Some people just have predisposition to develop such stones. Also, vitamin C abuse seems to be somehow associated with development of calcium oxalate. If I were you, I would know that as being part of a clinical manifestation. Now, whatever you want to tell your patients in your clinical practice, you may do so, but please know in medicine, that is important for us to take with us or hold on to. What's the other type? Well, we have the calcium phosphate. Whenever you hear about phosphate, you should be thinking about your pH becoming alkaline. Alkaline. Whereas if it's calcium oxalate, because of hypocytruria, it is decreased urinary pH. That is a huge point to distinguish between the two subtypes of calcium stones. Here, the rest of it, pretty much the same. Radiopaque, imaging study, let it be CT or X-ray. And the crystal here is wedge-shaped. Now here, what are the type of treatment modes that you want to keep in mind? Interesting enough, here's a diuretic. So here's a calcium stone that you have, but why would a diuretic come in handy here? It's not that the diuretic is being used to try to flush out the stone. Is that clear? Once again, listen, you're not using the diuretic, specifically thiazide here, to flush out the stone. You're specifically using your thiazide because think about where it works. Your thiazide sensitive receptors on the ductal tubule, responsible for, normally, it inhibits the sodium chloride channel, correct? Sodium chloride channel, and behaves like a diuretic. That's not what you're going for here. You have too much calcium in the urine. So what do you think this thiazide does? Yes, it actually removes the calcium. So if you're familiar with it, fantastic. If you weren't, get familiar with it real quick. Thiazides remove calcium from the urine. Now, very rarely, clinically, would you find a patient who's taken a thiazide that results in hypercalcemia. I can tell you that clinically. However, if you do have a patient that concomitantly also has a PTH problem, something like a primary hyperparathyroidism, obviously that's going to exacerbate the issue. Is that clear? Next, low sodium, and here's citrate as well. Those things that you want to keep in mind when dealing with calcium stones. Think of hypercitraturia. This is something that, for the most part, the citrate would then obviously be more in your plasma. So look for treatment here being thiazides, low sodium, and low citrate.